saying that I'm scared of the bell. Talk a little bit about some of the human rights considerations and concerns that one has in really being able to do implementation science or any research in general with people who inject drugs. And one of the sort of primary things that drives this over the last many years is really sort of making sure that you understand the context that you're in. And so I wanted to frame some of this related to what we know, here in Malaysia. And Malaysia is a middle-income country. In fact, it's a higher middle-income country. So you would think that you would have all the resources that you might need in order to do this work. But in that setting, it actually has a cascade of care, and there's some triangulation, and you can take a look at whether you're looking at the international data or otherwise. But if you take a look, it's a country that has an HIV epidemic that is concentrated in key populations. And if you take a look at the prevalence of disease in these groups, including people who inject drugs, each of these behaviors is criminalized. And so that really becomes one of the underpinning sort of issues that you need to think about, not only in the way that you recruit, the way that you think about the work, and even your sort of implementation strategies that you might use. And indeed, the cascade of care has some areas that have some pretty significant dropout. I don't think this is late, but you can actually see that there are contributions at each of these cascades as you're thinking about your implementation in terms of what's contributing to new infections, in terms of thinking about where you might want to implement. And even though that people who inject drugs are contributing to a smaller proportion of new infections in the country, there are secondary drivers because their sexual partners are part of that. And mathematical modeling suggests that developing interventions to improve the cascade of care for people who inject drugs will actually have an important outcome. These are data, and I'm going to use the socio-ecological model looking at the structural all the way down to the individual along that continuum in terms of your implementation science, and they are related to each other. But here's some examples that look across many different countries. This was Catherine Oldenburg, who is just a real superstar, looking at sort of categorizing a number of criminalization laws and the HIV prevalence in many different settings. And you have this really sort of nice category which looks at it. And if you begin to think about the groups, in fact, some of the work around people who inject drugs, you have this criminalization which starts out from police harassment, arrest going to maybe compulsory drug detention centers, or pusat serenti. It might be actual frank incarceration. And then, of course, there's the really dangerous risk that Sheila talked about with regard to prisoners. And I'll just skip over these because this is everyone else's. I want to point you, and I'm going to go through this very, very quickly. But there's a systematic review looking at human rights approaches and their impact. And there are 23 different studies, and they cover many different populations. They're in many different places around the world, etc. And they look at whether the interventions along the socio-ecological model involve the individual, the community, organizations, and the larger structural policies. And I decided to pull out a few of these 23 studies that actually had some different. Most of the studies had an impact, but what's really interesting, at least among groups that might disproportionately impact the police, and some of these were targeting the arrest of female sex workers. But one of the things that's very important is just by changing a policy, that in and of itself may not have an impact. But working to implement the policy with the end person who does it, like the police, will actually have an impact if you have an intervention that's actually working with it. Just changing the law, in some cases around syringe services programs and other HIV prevention, may in and of itself may not actually have an impact, but it requires some work in order to educate people within the community, including the police, who might actually, rather than arrest or harass people, move them towards harm reduction policies. And so there can be an impact across these different things. Now, I will say that Malaysia a few years ago was doing some work to begin to sort of move towards decriminalization. I feel like that this is really at the big structural level, but this will have a big impact. And we know from other examples elsewhere in the world, Adiba talked about the Malaysian context and how that may make a difference in terms of people attacking her on social media or any of these other sorts of things in terms of some of these changes. I will say that no matter which population you're looking at, the many veils of stigma are drivers, and I'm going to skip over some of these in terms of at the individual and the person who actually imposes the stigma. And this is a study just to give you a sense of where the stigmatizing attitudes start very early. This is a study of medical students, and this is a feeling thermometer, and you can see that this is medical and dental students, but there's a bunch of them. I mean, it's over 1,000 folks. And you can see that even though MSM are lowest on the bar here, people who inject drugs is still incredibly low relative to a general medical patient who might have diabetes. And so we have the potential to intervene early. So this could be a potential implementation to take a look at how that impacts care. And then if you take it to the next step, and this is really looking, I think, at what I would call the contact hypothesis. So you saw the people who were MSM had the most negative attitudes, but by the time you get to the clinicians, this is a study which looked at basically the intention to discriminate. And that is, they were given multiple scenarios. It was an experimental condition based upon CD4 count. I mean, the CD4 count at 17 is not debatable in any guidelines. This was after the 2006 guidelines, where it was basically treat everyone with HIV. And the question was asked, would you discriminate, but would you delay providing antiretroviral therapy? And if you take a look right over here at the right-hand side, you see the people who inject drugs. This was a group of individuals who, at least the providers, thought that they might withhold therapy for those. And there may be clinical reasons. They may incorrectly believe that they don't adhere to medications. Systematic reviews suggest that that's not the case. But what was really interesting about this is that you have the potential to have a mitigating factor in terms of how you might implement certain kinds of strategies. And the willingness to treat actually was markedly reduced with the provision of methadone. And what I thought that was really important is that when we take a look at some of these sexual and gender minorities, one of the things is that disappears. So you saw the medical students. This was a group of people who they saw these patients in their clinical practice. The contact hypothesis was that they began to know them. They know that these patients would show back up for medical appointments, and they had no intention to discriminate. Let me just skip over the next table. Basically, people who inject drugs was the biggest contributor. And so one of the things that I would sort of think about is I think about from implementation science where I might actually, where the money is. And from a social policy perspective, the decriminalization thing is still high and important on the list of implementation science. But I would also say that some of the things that got in the way of treatment for everyone, but specifically in very stigmatized groups, is really liberalizing the policies on the utilization of telehealth. And I think that that's going to be an important place to look. I think moving it down to the healthcare setting, this was something that I learned many years ago when, this was like 2000, and we were having conversations in sub-Saharan Africa about the 3x5 conversation. We were at a meeting with Joe Blanc, who actually, unfortunately, died in a Malaysian Airlines crash over Ukraine. Our dear friend Putin, who took him out of this earth. And one of the things that he said to me really, really stood out. There were actually two things. The first thing he said, everybody said, oh, you can't give medication because it's stigmatizing with all the HIV and stuff like that. Well, when you provide really good medication that's safe and effective, good treatment will often trump some of the stigma-related stuff. And that also relates to how you give your care. So I think that implementation strategies that sort of improve the quality of care so that the risk, the counterfactual, if you will actually be better. And some of the things to think about would be same-day antiretroviral therapy. Change the order. Instead of having someone come in and say, oh, what did you do to get HIV? Oh, I had sex with a man, or I injected drugs, or these things. Reduce that. Same-day treatment. Focus on the treatment issues. And there are good studies from sub-Saharan Africa where there's high rates of tuberculosis and stuff like that. Change the order in which you do things. We know that every study of integrating antiretroviral therapy and medications for opioid use disorder reduces HIV transmission and improves HIV treatment outcomes across the entire HIV treatment cascade. Why can't you do that in syringe services programs? These are touch points. These are places where individuals come for treatment. If they come to a methadone program, why are they not getting antiretroviral therapy? If they show up at the HIV clinic, why are they not getting methadone? These are all ways to sort of rethink what you're doing in terms of your implementation science. Incorporating the patient's preferences into treatment. And then, of course, you might say that you can have interventions that target medical students. I think Adiva's been doing that. Contact hypothesis, taking it one step further, working with clinicians. I hate to say this, but I've almost given up on clinicians. You know, unless you actually take the process out of it, I'm one of them. But I'm not sure that everybody's going to get it. So when you have these highly specialized HIV centers, you get the really good doctors who do that work, and they're really lovely and all that stuff. But they drop out of care because those systems are really tough. So when you decentralize, you don't have as much control over this. So I would rethink some of the things that we do. And then what can you do to reduce the demands on patients? People whose lives are somewhat chaotic, they can certainly pick up their phone and have a conversation with you, and you can actually suggest that they go take medication. Or if they're using, they may not feel like they want to come into clinic. Reduce things that reduce the demands on the individual, such as telehealth or teleprep. These are some things that we're doing in the US using mHealth to sort of reduce that interpersonal contact, you know, where people may feel stigmatized or they're going to be judged in a different way. I mean, I would just love to turn off my Zoom lens sometimes when I don't want people to see that I'm not looking at my best that day. It's the same for patients as well. And then, of course, I would say anything that you can do that Mona taught us about with streamlining services. You do the test and you move right to PrEP, you move right to antiretroviral therapy without having all of the sorts of things that get in the way of being able to get treatment. And you can imagine that the one reason why patients go to a doctor often is 90% of them want to walk away with a prescription. And so you want to do things to sort of streamline that. So that's the sort of the overview. I will just say that there's a really nice review paper that looks at the elements of implementation, research, and HIV prevention and treatment. It's worth taking a read. And I'll step off the podium before that bell goes off. I think she's been nice to me this time.